Hello. My name is Rafiat Akioko. I welcome you all to today's webinar with the National Challenge and the Sabin Vaccine Institute. At this webinar, the National Challenge Immunization Advocates will be talking about why immunization rates are declining and what healthcare workers can do to reverse this trend. As immunization advocates with the National Challenge and Sabin Vaccine Institute, we've been working on projects dealing with promoting vaccination. And we have across different countries, we have immunization advocates from Nigeria, from Sudan, from Lesotho, from Malawi, from US. And I welcome you all to this particular webinar. I am an immunization advocacy champion with the National Challenge and the Sabin Vaccine Institute in 2021. And I have been working on projects dealing with tackling vaccine hesitancy amongst indigenous people in Nigeria. So while we have this webinar, we will be talking, my fellow immunization advocacy champions will be talking about their challenges and the project they have been doing to promote vaccination, especially COVID-19 vaccination in their respective communities. I welcome you all to this particular webinar, and I'll be going on to Mpo Shelile from Lesotho to talk about, to introduce the immunization advocacy champions and to talk about the various projects in which we have been working on. Mpo, can I have you? Mpo, are you there?
Thank you very much. Thank you very much, Rafiat. Good morning, good afternoon, good day, colleagues. Like Rafiat has just introduced me, I am Mpo Shelile. I'm from Lesotho. Andrea, could you please project? Colleagues, welcome to this session. In fact, Rafiat has briefly touched on what I'm going to present about, the immunization advocacy champions. Colleagues, it was only in 2021 when the Nursing Now Challenge and the Sabin Vaccine Institute launched this new global solution initiative with the purpose of elevating the voices and perspectives of nurses and midwives with the aim of influencing discussion and decisions on vaccine equity and acceptance at local, national, and of course, at global level. Colleagues, as a result of this collaboration, we are from 7 countries. We are nurses and midwives, and we are the ones participating in this project. And because of that, at one point, we had to go for a 6-week training on storytelling. But the question is, who am I talking about? I'm talking about Amy from the United States of America, myself, Mpo Shelile from Lesotho, Mohammed from Uganda, Rashid from Malawi, and Rafiat from Nigeria. Okay. Colleagues, what we do as immunization advocacy champions is to encourage you nurses, our colleagues, to join advocacy activities. Yes, we do have the activities. We did write our activities that happened to win the Nursing Now Challenge Global Solution Initiative. So we want to replicate our winning advocacy ideas to you, to the whole world. Otherwise, we wish to collaborate with the Nursing Now Challenge to create and of course lead webinars like the webinars we are on today. Workshops. We also want to engage with global nurses and midwives on the importance of storytelling when it comes to the promotion of vaccine equity and acceptance. So colleagues, the main reason why we exist, it's simply to raise awareness. It's simply to promote vaccine equity and vaccine acceptance. Well, as individuals or as individual participants to this project, we had to develop our advocacy plans. And we did those in our capacity as Nursing Now Challenge and Sabian Vaccine Institution Immunization Advocacy Champions. Colleagues, later today, during this webinar, we will share with you what we've been doing, the experiences that we've had since joining this project. And we'll also share with you some of the achievements that we managed to reach since we joined this project. Having said that, colleagues, thank you very much. That's briefly what immunization advocacy champions are all about. Thank you very much, Rafiat.
Thank you so much for such a wonderful introduction to what we all as immunization advocates have been doing, and also the challenges, what we have been doing so far for the past 1 year. It's really nice having you here, Mpo. And I also have Vince Desa from the Sabin Vaccine Institute. Vince will be talking about how the COVID, how to address the global backside in vaccinations. Currently, there has been reports by the UNICEF that routine immunization and vaccination has declined since the advent of the COVID-19 vaccination, since the advent of the COVID-19. So we want to discuss about what could be, how is the backside affecting us, and how the global backside in vaccinations in general. Vince Desa, it's a pleasure to welcome you here, and I hope to have a very wonderful experience with you. Can you come on stage, please?
Thank you very much, Rafiat. It's good to be with you all again. Sorry, colleagues, just give me 1 second. Can you all see my slides?
Oh yes, I can see your slides.
Great. Okay. Well, yes, thank you very much, Rafiat, and it's great to see all this group together again, and thank you all for joining us today. We want this to be an open discussion with all of you on what you're seeing in immunization in your communities as well. And so I think there's some questions in the chat. Encourage you to put your experiences in the chat as well as questions, and we'll have time for some open discussion at the end. But to just get us started with the topic for today, we just wanted to touch on what Rafiat was just sharing, some really alarming data that has come out from the World Health Organization and UNICEF regarding routine immunization. And I think the last few years, of course, we've all been very focused on COVID vaccination. But just to start to remind everybody, I don't think I have to convince anybody likely that's on this webinar, but of the tremendous transformational power that vaccines hold. And there's been some research over this last 2 years, especially that have really underscored just how impactful vaccines can be. In vaccines that were administered mainly to children in the first 2 decades of the century, that's going to prevent an estimated 50 million deaths across 112 low and middle income countries. those are just vaccinations from 10 diseases, and those diseases are noted on this slide. And then, of course, we all have been enveloped in the COVID-19 vaccination discussions and rollout. A Lancet study out this year estimated that in just the first year of the COVID-19 vaccine rollout, it saved almost 20 million lives. And so I think we've all been, focused rightly on the lives that we lost and trying to prevent more. But it is a pretty astounding testament of a public health intervention saving nearly 20 million lives in 1 year. And of course, they are a huge economic driver if implemented. That there is an estimate out from this past decade that for every dollar spent in low and middle income countries on vaccinations, it saved $44 for that economy, which is, a tremendous boon for economies. But this power, unfortunately, has had very inequitable impact, as we know, with COVID-19 vaccines. And this on the left here is the tiers of income of countries. You'll see some of the upper middle income countries have actually gone above the high income countries recently, but low income and lower middle income countries really not getting nearly the equitable impact of COVID-19 vaccines, and especially over the first year of the rollout. The UN Development Program estimated that if the rate of COVID-19 vaccine uptake in low-income countries had they been able to access COVID-19 vaccines at the rate of high-income countries, it would have increased the gross domestic product by more than 5% in those low-income countries, and which is over $16 billion. So tremendous potential. In the case of COVID-19 vaccines, very inequitable impact. But a broader impact of this pandemic has been the impact that it's had on routine immunizations. And these are mostly the vaccinations delivered in infancy and early childhood to under fives. And this is the headline from WHO and UNICEF. This data was just out on July 15th, so it's very new. And it's data from 2021, and 25 million infants and young children missed out on these life-saving vaccines in 2021. It's the longest sustained decline in nearly 30 years of vaccination. And of course, there's a lot of different reasons for this. Pandemic shutdowns, there's a lot of health-seeking behaviors. People did not come out as much for immunizations and that sort of thing. But of course, some of the similar issues that there's been in COVID-19 vaccine uptake, especially some of the prevalence of misinformation and disinformation, issues around that have impacted routine immunization as well. So this is just a slide from the WHO and UNICEF showing where the coverage has been since 2000, and you'll notice you see a decline in the these last 3 years, 2019, 2020, and 2021. This is for the diphtheria, tetanus, and pertussis vaccine, the DTP3. It's one of the main vaccines that is tracked to show how well an immunization system is functioning. And so it has declined from 86% to 81%. Now, that's a 5% decline may not seem like much, but that's millions. That's millions of children that are missing out on those vaccines. But you also see there was, before 2000, there was a pretty significant increase. And there was an increase all the way up until 2010. But it was after the previous decade, it was relatively flat, only marginal increases. So while the pandemic has definitely driven a downturn in vaccination rates, this flat rates of missing children every year has persisted for the last since at least 2010. The rates are fairly high, but these children you see at the bottom here, they're called children that have never received a single vaccine in their life, the zero-dose children. And you see here that there was 13.3 million of those in 2019, of those zero-dose children. That has increased to 18.2 million in 2021. And so, reaching those children is extremely important, and it is often nurses and midwives and other frontline health workers who are reaching those children. And so we're really interested in hearing from you all as to experiences that you've had on what has changed and what has not changed in the communities that you're working with and trying to get vaccinations out to. This slide really shows that the decline actually happened in every single region of the world. At the bottom of the slide, you'll see what the World Health Organization regions are here. And so, some regions had been higher than others, but for the past 3 years, 2019, 2020, 2021, there's been a decline over that period in every WHO region. But that does kind of mask that within the regions there are some glimmers of hope. Gavi, the Vaccine Alliance, which supports a core of 57 lower-income countries to deliver vaccinations and to purchase and deliver vaccinations, just did an analysis of this new data that came out from the World Health Organization and UNICEF. And this is the change in the DTP3 vaccination just from 2020 to 2021. And you see among these countries that some countries had some significant decreases, some really major decreases, but some countries had increases. This was after potentially having a decrease in the first year of the pandemic. There were some significant increases to catch up. The Gavi and UNICEF have noted, in particular, Chad and Pakistan have had some really significant increases. Pakistan is over the pre-pandemic levels of vaccination. And one thing that UNICEF, us here at SABIN, and the World Health Organization have all really emphasized in reaction to this report is it is really that focus on that primary healthcare delivery, on those health workers, that intense focus on those communities, on those health workers who are delivering vaccinations, that has proven time and again, and it has definitely proven also during this pandemic, really has an impact. So you can see in the New York Times coverage, the head of advocacy for UNICEF, that her quote at the end was, "We aren't going to solve this with poster campaigns or social media posts. You need outreach by reliable, well-trained, properly compensated community health workers who are out there day in, day out, building trust." And that's obviously community health workers in some settings. It's nurses, it's midwives, it's all of those who are at that point of service in the community. This is the piece on the right's our statement here. We really need to act for those, for you all, the new investments in health workforce and primary care, so that you have more tools to deliver. And so I think with that, I'm going to play a video from the World Health Organization about this data, but really interested in hearing from the experiences of you all and being in further discussion today. So I will go ahead and play that video now.
When COVID-19 hit, where you were in the world determined the course of your life thereafter. How quickly your government reacted, how easily you accessed healthcare, whether you could work or go to school, lost loved ones, kept connected, stayed alive. Science found solutions, yet the biggest vaccine rollout in human history has also revealed the long-standing inequities facing humanity. Across all vaccinations, all diseases, all pathogens, and all countries. These inequities won't end until we close the gap. Until the vaccine divide is closed. And the knock-on effects of inequitable access to primary healthcare and technology stop posing dire and dangerous threats on both our lives and our livelihoods. The power to close the vaccine gap lies with all of us. So what are the decisions we need to be making? Keep vaccinating to reach our targets. Keep building production capacities. Keep preparing for the worst and keep strengthening for the future. Failure to fund, support, lead and prioritize primary healthcare is a dangerous risk we cannot afford to take. The future will arrive, more disasters will strike, and right now is the only chance we have to make sure we're ready. Together.
Okay, so Rafiat, with that, back over to you. Thank you.
Thank you so much, Vince. That's a very wonderful presentation. Really, it's really sad to know and to understand that we are actually at risk. Everyone is at risk because by 2030 we actually have a goal of immunizing 90% of the population people, and this goal is actually threatened. And we all have a role to play as healthcare workers, as frontline workers, to deal with this challenge because it's a global challenge, and we can't just fold our hands and watch this happening. And this is why we have to come to a discussion by the National Challenge and Establishing Vaccine Institute Immunization Advocacy Champions to talk about what healthcare workers as frontline workers have to do to tackle this challenge of reduced immunization globally. So we all have our immunization advocacy champions here. We have Rose from Uganda, Rashid from Malawi, Amy from the US, and Paul from Lesotho. They all will be discussing on how the COVID-19 pandemic has affected health-seeking behaviors and what healthcare workers can do to improve the current situation. Considering the level of experience that we've all had in promoting vaccination within our communities, I think we all have one or two things to share about what we think could be done to improve the current situation that we have found ourselves regarding COVID, regarding decline in routine immunization. So I'll go to Rose first. Rose is an immunization advocacy champion from Uganda, and she has been doing an impressive work with storytelling among nurses. Rose, I'd like to know about your views and what you have been doing around in your community and what you think could be done as an healthcare worker to bridge this gap. Rose, thank you very much for coming in.
Thank you so much, Rafiat, and thank you so much also for being so. I hope you can hear me.
Yes, I can hear you.
Okay, thank you. So to start us off, it's also imperative that we recognize that only about 37% of healthcare workers in low and middle income countries are vaccinated. This implies that the lack of vaccine confidence, it also spans across the healthcare workforce. And we need to do something about it. And we also need to do something about it for the population. In light of all this, all hope is not lost. If we are to reach a state of vaccine equity, we have to also recognize the areas that are impacted most. UNICEF says, quotes, that it's mainly remote rural areas, urban poor populations, and areas with conflict and disaster that are affected mostly. And where if we need to really reach vaccine equity, we need to be increasing our efforts in such populations living in those areas. So our work, the work I'm involved in, targets one of those populations, that's the remote rural populations, and the people who serve them, the rural healthcare workers. Well, storytelling is a tool for advocacy to strengthen the healthcare system, but it's an information tool that gets information to policymakers, decision makers, to fellow healthcare workers, and also to the public to build trust back into the healthcare systems. In Uganda, the COVID-19 pandemic has greatly affected all populations, but vaccine inequity has been registered mostly in the age group of 12 to 17-year-olds. And so right now at this moment, the country is trying to figure out how we get back into a mass vaccination campaign where we get shots into the arms of the 12 to 17-year-olds and get them immunized. And this would help us increase the population that is targeted to be immunized from 56% to hopefully the 70% that we are targeting to get immunized. But to immunize this population, there are a number of stakeholders that are involved that need to be engaged and that we have been engaging. For example, the religious leaders, the Ministry of Health officials, parents, Ministry of Education, the civil society organizations, migratory agencies, funding agencies, social mobilization change agents, community leaders, political leaders, and religious leaders. Getting all these stakeholders into rooms to be able to reach a similar pages with the work that I've been involved in greatly, and having these discussions of how to reach these populations that are already left out of the vaccination campaigns. And some of them are in hard to reach areas. How do we get shots into their arms so that we increase the number of people who are vaccinated? But engaging them requires us as healthcare be able to utilize storytelling effectively to tell compelling stories that highlight the context of how we are working, the context of our operations, the challenges that are faced in getting to these populations, whether it's to move in canoes over water to get to these populations in islands, And whether it is the challenges of hard to reach areas, mountainous roads, where we have to create mobile outreaches, and whether it's late payments. For example, in Uganda, prior to this round 3 mass vaccination campaign that I was involved in, healthcare workers had not been paid for round 1 and round 2. It's notable from what my colleague Vince Blesser said, that, quoting the UNICEF person, that the healthcare workers need to be motivated. All of us healthcare workers need motivation. We need to be well compensated to tolerate these hard conditions. So we need to be good advocates for ourselves, to get ourselves paid, to not only get ourselves paid, but to ensure that we are motivated to deliver the kind of vaccine delivery that is needed to reach vaccine equity. But also we need to highlight successful stories. We need to utilize case studies to show what are we doing irrespective of the challenges that we face. These case studies can go a very long way to not only share best practices of what's working and what's not working in low resource limited settings, whether you're in a high income country or a low income country or a middle income country. To know what is working in one place could help share the knowledge. You could share that knowledge with other healthcare workers in other settings through case studies so that they can adapt these best practices and tailor them to their own settings. This is a global pandemic and all of us are learning as we go along. We need also to continuously have, as healthcare workers, to share immunization summary reports, up-to-date information, and see what are the changes in vaccination numbers as we continue to vaccinate. So for me, as a person who's helping healthcare workers to tell the stories, it's imperative that we are continuously not only telling stories that show the whole picture, but also getting these stories in front of policymakers, academia, and everyone has a stake in ensuring that the health system becomes much more resilient and it serves the people who are vulnerable and disadvantaged much more better to get everyone vaccinated. Thank you.
Thank you so much, Rose. I really enjoy your discussion. I was particularly interested in the parts where you talked about, training nurses about storytelling to talk about unique stories that affect them. You also talked about sharing case studies, and then when you actually know what happens in a particular community, you can learn from that and then incorporate that into what you're doing. And I think particularly nurses should be more involved in case studies and research, and then sharing stories and their experiences, because really there isn't an island of knowledge, and everybody is just learning to know what could be done better in a different way. So I really enjoy your perspective about that. Thank you very much for sharing that with us. So we currently have a little bit of issue with the chat function, with the chat box function. So while we apologize for that, when we get to the question and answer and the discussion part of this webinar, you can easily raise your hands and then you'll be called on to ask questions directly. Thank you very much. While I move away from Rose, I'll be going to Rashid. Rashid is an immunization advocacy champion from Malawi, and he has been working on vaccination during vaccination in hard to reach countries and in places faced with natural disasters. So Rashid will be talking about vaccination during an outbreak, how his own experience about how he has been able to achieve natural disasters and his opinions about how to vaccinate people. Are you there with us? Hello, Rashid. Oh,
Hello, Lafiat.
Hello, it's a pleasure having you here.
Thank you so much. Can you hear me or?
I can hear you.
All right, thank you. So I'm going to close my video so that you can hear me clearly with the connection problems that I have. So bear with me on that one. Yeah, so I'm going to share a little bit of my experience in delivering different vaccines in hard-to-reach areas. So Malawi has been affected by a number of outbreaks and also disasters. So I'm going to share experience in delivering routine immunization and also COVID-19 vaccines in this situation. So if you can allow me, I'm going to share my screen so that you can understand better. Yeah, so this is just a background of vaccination here in Malawi, which was launched in March 2021 by our president, Dr. Lazarus Chakwera. So this is just a background of vaccination in Malawi. I'm not going to spend much of my time. These are just the strategies that we've been using in delivering COVID-19 vaccines. So a bit of background of COVID-19 vaccine delivery in flood disaster areas. So Malawi was hit by cyclones in December 2021, and Palombe district was one of the districts which was heavily affected, and about 15 households were affected and were displaced from their homes. So during the aftermath of the floods, we started response activities, which included COVID-19 vaccine delivery in evacuation shelters across the district. So a bit of background for the outbreaks that we've had. So we had polio outbreak and the cholera outbreak in Malawi. So Malawi reported a first positive polio 1 case from a 3-year-old child with no history of travel. And this child was located in one of the districts here in Malawi, which is Lilongwe. The child only received single dose of OPV, which she received at birth. After that, she never received any other polio vaccine. So this is just to explain when was the case tested and also the confirmation that was made. But the important part is that polio was declared public health emergency in February this year. So a few weeks later, we had another outbreak on top of flood disaster that we had. Polio outbreak, then we were also affected by cholera outbreak, and it was declared an outbreak in surrounding district. So Palombe, which is my district, is also prone to cholera, but this year we were spared because of the interventions that we've been doing. So like many other districts, Palombe started responding to these outbreaks with different interventions, which included vaccination activities. So I'm going to share the experiences during the outbreaks as far as vaccination is concerned. So above all, we continued delivering COVID-19 vaccines in hard-to-reach areas through outreach clinics. So we thought of integrating the services. We were giving COVID-19 vaccines together with SRH services and the routine immunizations. Though we had some resistance from the communities, I remember at some point we were chased by the community members because they thought we brought them COVID-19 vaccine only, not SRH services. So they were reluctant to get COVID-19 vaccines, but they wanted SRH services. So at that time, together with my fellow nurses, we brought the SRH services only. But then we were chased, they thought we were lying to them. We brought COVID-19 vaccine rather than sexual and reproductive health services, which include family planning services. So we were also integrating with routine immunization, as I've already said, but we had a challenge with this one because we started experiencing low turn-up in routine immunization. We started seeing low numbers of women coming with their children to get immunized because of the same reasons. They thought that the routine immunization that we were administered to their children were not actually the immunization, like the polio vaccines, the DPT. They thought it was COVID-19 vaccine. So they thought of not coming to these outreach sites to get their children vaccinated. So after this, we started doing sensitization activities and awareness campaigns in schools, in health facilities across the district. So with my fellow nurses, I had this other project which was sponsored by Nursing Now. I had to move around all the facilities in my district. In total, there were 14 health facilities to sensitize all healthcare workers on COVID-19 vaccines and COVID-19 in general, because healthcare workers were on the forefront, spreading misinformations, myths to the community. So we thought of organizing this activity so that we can start by, removing these myths from the health care workers who are trusted by the people in the community. So we also did the same in schools. We launched some drama groups on COVID-19 vaccinations. We also did interface meetings with local leaders in the communities, and also finally we pasted the COVID-19 information communication materials in the camps and schools as well as health facilities. So after that, I'm going to share you a brief experience on polio vaccine. So after that COVID-19 vaccination, we launched polio vaccination campaign following the polio outbreaks that we had. So from the national level, they demanded that we should strengthen routine immunizations, which included polio vaccine. And after that, we should also do campaigns on polio vaccine, which we called polio SEER, which means polio supplementary immunization activities. So we had to do this activity on top of the routine immunization that we do. So we grouped this into 4 rounds, and now we are doing the 3rd round. So the target was to vaccinate with this polio vaccine, oral polio vaccine, to all under 5 children. So the strategy that we used, we had to go door by door, to vaccinate all under 5 children in each and every household. So we on top of that, we also had to visit some fixed sites such as markets, schools, health facilities, and what have you. We also had to do finger marking and door marking so that we can identify, we can know that this child was already, vaccinated with this OPV. And then also do door marking so that when the other team, because it was like flat out, all healthcare workers were deployed, it was, the round was being done 5 days. Only for 5 days. So all healthcare workers were deployed in the communities to do this activity. So the marking was just to identify that this household has already been visited by the other team. So in May, we launched also oral cholera vaccine in our district. So this activity was only done in 5 facilities that were that are prone to cholera. So these facilities are located near the lake, and also they are prone to disasters. So we thought of doing the campaigns, the oral cholera vaccine campaigns in such areas, so that we can prevent people from getting this cholera. So the target of so the targeted population was all people above 1 year. So we did this activity in the for the first round in May 2022. So we are here to do to start another round next month. So the challenges that we've been facing, starting from delivering COVID-19 vaccines in during the disaster outbreaks. So the first challenge that is common here in Malawi, in particular in Palombe district, is that of and misinformation. This is a big challenge to us because some of this misinformation is coming from trusted personnel, which are healthcare workers. So we all know that people in the community trust healthcare workers most. So when they tell lies about any service, people in the community trust them. So as I mentioned, we had to do an activity just to address this challenge that we've been having. So far, we managed to visit all the facilities, as I've already mentioned earlier on. So we also had another challenge where oral cholera vaccine and the oral polio vaccine campaigns created burden among healthcare workers. As I said, that this activity was done flat out. All the healthcare workers were deployed in the community to do this activity. So other services like COVID-19 vaccine, routine immunization were crippled, were affected because all the people concentrated on these campaigns, OCV and OPV campaigns. The other challenge is that of integration. We are having a lot of challenge in integrating COVID-19 vaccines with other services like family planning services, routine immunization, oral cholera vaccine, and the oral polio vaccine. So this is coming in when, for example, we've gone to the community with oral cholera vaccine. They think we are tricking the community that we've brought COVID-19 vaccine, not oral cholera vaccine. So whenever we take cholera vaccine and COVID-19 vaccine together, the community are very reluctant to receive any kind of service that we brought to them at that particular time. So it is becoming a challenge for us to integrate COVID-19 vaccine and another service that requires, inoculation or any kind of vaccination. The other challenge is poor terrain. As I said, that most of our areas were affected by the cyclones that we've had. So some areas are difficult to reach. Our vehicles cannot reach, our motorcycles cannot reach in those areas. So we're having challenges in delivering COVID-19 vaccines and other vaccines in such areas. The other challenge that we've been facing is that of default. Later, we've observed that we have a lot of people that have defaulted COVID-19 vaccines. We have a lot of people that received first dose of COVID-19 and they have not come to get their second dose of COVID-19 vaccines. After some assessment, we've just discovered that because maybe the cases have reduced, so the people are no longer interested in COVID-19 vaccines. That is the most response that we get from the people that we interview. The other challenge is that obvious challenge of religious beliefs. and also community resistance. As I said, at some point we had our healthcare workers being chased from an outreach site. So this is affecting vaccine delivery in some sites. So the best practices so far, we've just learned that when we show the community, when we compare the vials of different vaccines, for example, we have COVID-19 vaccine vial and oral polio vaccine vial, and showing to the community, they tend to understand quickly than just getting the vaccine and give them. But when you show, do you see this? This is the oral polio vaccine, and this is the COVID-19 vaccine. Are these vials similar? They say no. Then after consent, we go ahead and give them the vaccine that they desired that particular time. This has worked in some areas, because at first we are just going with, for example, OPV or OCV vaccine only without getting COVID-19 vaccine vials. So when it was very challenging for us to deliver oral polio vaccine without showing them, without comparing it with, COVID-19 vaccine vial, so that they can be sure that the vaccine that we are giving them is not COVID-19 vaccine, rather is polio vaccine or cholera vaccine. So this has worked very well so far. We have also been doing the advocacy activities, as I've already mentioned. We've done this in health facilities, in secondary schools as well as primary schools. We also did this in evacuation camps that we've had in the district. In addition to that, we've also been doing vaccine campaigns. As I've said, we launched oral polio vaccine, oral cholera vaccine. So
hello, Rashid. Hello.
Hi.
Yes, I am so sorry to interrupt you, but we have very limited time right now, so we would really appreciate if you could wrap it up. So
okay.
We have other panelists in there. Thank you.
Thank you. So these are the other, maybe you can see from there, these are the other best practices and the success that we've had in the district. And thank you so much for your attention.
Thank you, Rashid, for your presentation. It's really touching, seeing the challenges you have to face in Malawi, coupled with the COVID-19, polio, and cholera outbreak. And it's also really interesting knowing and learning what you have been doing to tackle this challenge. Thank you very much. We really are out of time, so I would like to talk about care. So Paul, can we have you? You have sorry, Paul, can you talk for just 2 minutes? We would appreciate you talking for 2 minutes. Thank you.
Thank you very much, Rafiat. Colleagues. Mine is just a short one. I'm going to share with you a strategy that has proven to work in our case here in Lesotho. Well, it's probably being used in other countries, but what I've seen is that the incorporation of COVID-19 vaccination in our primary healthcare helps a lot in terms of increasing vaccination. What I've seen happen here in Lesotho is that whenever people come for primary healthcare services, they'll be screened for everything, the hypertensions and so on. And when they're done, they'll also be asked whether they've had their COVID-19 vaccine or not. If not, they will be referred to the right corner where they'll get their COVID-19 vaccine. But colleagues, I must mention here that, yes, it's a common practice within the nursing profession that we do health education. But what I've seen in our case is that we go even beyond health education for us to convert, for us to do what? to convince people to take their COVID-19 vaccine. What we have done is that we have employed effective engagement skills. And these are far more than the health education that we are used to in our primary healthcare settings. What we do is that we want to tap into our clients' decision-making process. What we need to do in as far as this approach is concerned is that we need to connect with these people on a human level, build rapport, trust, and relationships. Otherwise, as you are in this process, you need to be an active listener. Otherwise, you need to probe actively to explore the reason behind the reason for not vaccinating. And as you do that, as a healthcare professional, as a nurse, you need to demonstrate the knowledge, expertise of the subject matter. Then you'll be able to tap into the decision-making process of this person. Otherwise, you need to show some energy as you present your product, as you present your intervention. It has proven to work where we show confidence and, of course, energy as we try to convert our non-believers into endorsers and ultimately believers of COVID-19 vaccine. And colleagues, let's always position our health education as a problem-solving education. We have heard of how storytelling helps. We have heard what happens in Malawi, where people would think polio vaccine is a COVID-19 vaccine. If we position our education such that people will understand, then we will win this battle. Lastly, colleagues, more importantly, we need to communicate clearly and concisely to our patients and clients as we integrate, as we bring in COVID-19 vaccination into our primary healthcare settings. Thank you very much.
That's a wonderful presentation, Umpo. I've really had a whole lot. You know, as nurses, I believe that we really are closer to the community. We are closer to our patients, and we have to communicate clearly and concisely in a very confident manner. And I think the confidence really matters when we communicate. And it is the kind of energy that we put out there that people would really follow. So really, that's a very nice one, Umpo. And to save our time, I'll be going to Amy. Amy will be talking about building trust when in the face of COVID-19 vaccination. Amy, can we have you? You have just a few minutes to talk. Thank you very much.
Hi, good morning, everyone. My name is Amy Staley, and I, like my colleagues here this morning, have the greatest job in the world. I am a registered nurse. On work days, I clock in around 7:15 to begin my 13-hour shifts. 13 hours can very quickly become 16 hours, which turns into 17 hours. And at some point, you really just stop counting. Kind of like this pandemic, 1 week turned into a month, which turned into a year. And at some point in between this time period, the United States took a pivotal turn. Some would argue that vaccines are a political issue. Others may say that they go against their rights and beliefs, but it's almost 7 a.m. and I am just trying to get my car across the George Washington Bridge, a structure that was created to connect two states together, yet I have never seen more division in my life than what I have witnessed unfold over the past 3 years. It's 7:05 and I am listening to individuals who once referred to nurses as heroes just 1 year prior, in the same breath proclaiming healthcare workers to be manipulators, individuals who must be making money off of administering vaccines, and worst of all, killers. It's 7:10 and I am listening to the numbers. COVID cases predicted to peak in New York City, August of 2022. New York State declares state of emergency over monkeypox virus vaccines available. The spread of misinformation surrounding the COVID-19 pandemic and vaccinations in general has overtaken the communities that we serve. It is through listening that I determined the 3 following best practices for nurses looking to improve health-seeking behaviors. First, earn trust. Trust is built when science and facts are presented in a way that anyone can understand. This is paramount to encouraging others to take charge of their health and seek care, whether that be preventative care or through a vaccination or any other kind of treatment. Second, be transparent. Address concerns with empathy and respect. Transparency creates a dialogue with the individual while maintaining the integrity of the information at hand. Third, be patient. There comes a point where it's no longer about a vaccine or an injection, but rather caring for the humanity of one another. There are numerous barriers that prevent our patients from seeking care. Personal beliefs, finances, childcare, economic conditions, and sometimes just fear of the unknown. Take time to listen. Your presence and patience are the most valuable tools needed to bridge any gap. With these tools and the persistence of the greatest profession in the world, America's most trusted profession, nursing, we can influence and improve healthcare for all. It's 7:15 and our shift begins now. Thank you for taking the time to listen, and I appreciate all of you joining us here today.
Thank you, Amy, for that short presentation. Building trust amongst nurses is very important. That trust brings about transparency, and then when we trust each other, people can be able to trust our decisions and our advice and even whatever else education that we have to bring about. And I would like to say that you're so good at this. You're good at storytelling, and that's a whole lot to learn from you. Thank you very much, Amy. So we are rounding up our discussion, and we'll be giving our participants we'll be giving them the space to ask questions, and also ask any question that you have with the panelists, and we'll be glad to answer your questions. You can use the raise your hand. You can just raise your hand, and then when you raise your hand, we'll call you directly to ask your questions. You can direct the questions to any of the panelists. Thank you while we await your questions.
Rafiat, I think Anna was the first to raise her hand. If you want to have her go first.
Oh yeah, Anna, can you go on? Hello.
If Anna, you're not there, Mary, I see you also raised your hand.
Yes. Good evening, good afternoon, good morning, everyone. My name is Mary. I work with the Global Health Collaborative as the Research and Infrastructure Manager, and I'm happy to be part of this discussion and presentation. Thank you, everyone, for the work you're doing. And looking at the challenges with vaccine accessibility in Uganda, and then I have observed that some of the challenges we have when the COVID-19 came, the vaccine started, and then there was really not enough time to tell people why do they exactly need the vaccine. I think the campaign to encourage communities to take up the vaccine has not really been effective in the country. And there is really a lot that needs to be done. This is a local community where we have what we call the community gatekeepers, like the elders, the religious leaders, the community leaders, need to be involved. For example, in the community where I come from, if you want to do something, you need to get through the LC1 chairman. And if the LC1 chairman approves something or a campaign and calls people to be part, chances are high these people are going to listen than even when you put on adverts on radio and even on TV. So people have leaders, the local leaders they trust. And I feel like in one way or the other, these leaders have not been involved a lot in the campaigns for vaccine. You have seen that some of the hindrances are the religious beliefs, but the religious leaders, I wish there was like a call to call these people and like make them understand how important vaccination is. If my leader in church, for example, the Archbishop of Uganda believes, and the leader at my local church believes, and they sit with me and tell me that this is something that is good. I, as a leader, have taken up the vaccine, and I encourage you people to take up the vaccine. This could be a success. But I feel like these people have been, in a way, not been put on the front of vaccination campaigns. Then another challenge I feel that is need to be tackled is the cold chain maintenance. We have had issues where the vaccines come, they are put into they are supplied to the communities, but when they are supplied to the communities, because the fridges there do not hold the vaccines to the required temperatures, when they reach the communities, they don't take long. 1 month the vaccines are out, then before the end of the month, they are calling people that the vaccines are getting expired in these days. And then people come gather at the vaccination center and there are no vaccines, just because like you find that a lot of vaccines have been wasted. They have expired, and by the time they come, the numbers cannot be put together to have all these vaccines used. So if we need actually to succeed, a lot needs to be done on my side, such that we can have these vaccines. If they reach the communities, can they stay longer? If they cannot stay longer, can we bring just a little that can be taken up? Some of them, if one vial is opened, they cannot open the vial unless the number that is going to take up the entire vial is there. So people come and they are bounced back. And when they are bounced back, it is hard to bring them on board again. So thank you, the nurses that are putting in efforts to advocate for vaccine accessibility, but I really feel more energy is needed. Each one of us has a role. We have had health workers. I was part of the study. I participated in a study that was assessing the acceptability of COVID-19 vaccines among health workers in Masaka district, Uganda. But you realize that many health workers actually didn't get the vaccines themselves. So how do you expect these people to take up the campaign, to call people to take up the vaccines? So even health workers themselves need to get the trust. Thank you. Someone has mentioned about building trust. People need to build trust within these vaccines. The health workers need to accept the vaccines and then sell them to the rest of the communities. Thank you so much.
Thank you so much, Mary, for that very insightful opinion. I think that you really touched the fact that everyone has a role to play, from even religious leaders to supply chains, people handling supply chains, and we also need to strengthen our healthcare systems. I don't know if Rose, do you have anything to say, considering the fact that you are an immunization advocacy champion in Uganda, and this might be a particular challenge in Uganda. Do you have something to tell us?
I think her concerns, Namixa's concerns are valid. As recently regional program coordinator consultant for the recently concluded round 3 mass vaccination campaign. And what we noticed was the mobilization strategies. So the project I was consulting on was a funding mechanism by USAID for the nationwide campaign. But the challenge is the Ministry of Health did not have the monies to be able to support mobilization and mass vaccination campaigns, which increase access to vaccination by taking the vaccines nearest to the population, utilizing various strategies from mobile vaccination sites to outreaches to stationary sites, a number of strategies. So when USAID came on board and through a funding mechanism, EPIC project, which I was working on to support that, the start of the mobilization and the start of the campaign were not done together. So the mobilization was done when the campaign was about to end. So it reduced the numbers. It somehow hindered in realizing the real target numbers that we wanted to reach. But you're very right. I think there is some need of effort that is needed to really address, to really target the healthcare workers themselves. Because even the healthcare, I can reliably tell you, even some of the healthcare workers who were working with me were not immunized. And they were laughing at me very heavily, you know, how I had even a booster shot. So it's a big challenge for us to get even the healthcare workforce to be immunized in the first case, and also to be able to continuously engage site stakeholders. But thank you so much for that.
Thank you. Thank you so much, Rose. Thank you for sharing your opinion. That's a really valid one. And if we are in this fight together, and I believe that if we have to tackle the issue of vaccine hesitancy, myth and misinformation, we need to start with the healthcare workers, because really these are the people that can convince people out there. We are trusted people, and if we are not taking the vaccine, then how are we going to help others in taking the vaccine? So it's a collaborative fight, and we are all in it together. I would like to call on David Bryan. David Bryan raised his hand. David, are you still there?
Yes, I'm here. Thank you so much. This is David Bryan with the Frontline Health Workers Coalition. And I want to thank everyone on this panel, because you've presented such powerful stories and expertise in terms of your analysis of what needs to happen to really deliver vaccines appropriately and address the gap that we're seeing. So I was just very moved by your testimony. I look forward to the recording on your YouTube channel. I wanted to ask any of on the panel, if you had 5 minutes with your Minister of Health, what would you say to that person in terms of what needs to happen to address the challenges that you're seeing?
Okay. Thank you, David. Is there anyone here and panelists who would like to answer that question? Rose and Paul. Would you like to answer that?
Number one, I think there is need of a transparent conversation with the healthcare workers and the manufacturers of vaccines, or the companies that manufacture vaccines, because most of the healthcare workers are very the conversations I've had with the healthcare workers. So there is need of creating some kind of Zoom meetings or conferences rather to increase the healthcare workers' confidence in the vaccines. And then number two, we need to also to increase the number of people turning up for vaccines. We need to look at the mobilization strategies. There is no one strategy fits all approach, but there is an ability to have timely mobilization, which starts at the same before and almost at the same time when vaccination starts, mass vaccination campaign start. rather than mobilization strategies starting at the end of vaccination campaigns. Then thirdly, areas where vaccine inequity is greatest, from remote rural areas, urban poor areas, and also areas with food insecurity countries and conflicts. Ways of seeing how do we work with security agencies to healthcare workers that they will be. So we need different strategies to reach this. We need to increase financing for mass vaccination campaigns that are targeted, that are in these areas, so that there are a number of strategies that are utilized within these areas. And fourthly, there needs to be quick payment of healthcare workers, because delayed payment demotivates healthcare workers, most especially because they're already getting low salaries, and then they're being tasked to move to these areas, sometimes on their own transport, and they're already earning very low salaries. So this demotivates them to be able to turn up for vaccination campaigns and participate in them and improve vaccine delivery. And something that I also have seen that might be taken for children 12 to 17-year-old, there needs to be multi-stakeholder engagements, including their parents, to be able to see how do we get shots into the arms of children with their parents' consent. Because without that, without this kind of discussions with the parents and increasing the confidence, or increasing vaccine confidence among the parents, most especially, and the Ministry of Education or and other stakeholders around the education sector, it's likely that this kind of population, the 12 to 17-year-old, will still be left out. Thank you.
Thank you. Thank you so much, Ruth, for sharing your opinion. Paul would also like to share his opinion about the question David raised. So, Paul, can you come and share your thoughts?
Thank you very much, Rafiat. David, what I would do, simple. The minister should need to regulate communication medium, regulate social media. There was a lot of misinformation that was spread via social media. Secondly, they need to invest more on nursing. We can have vaccines if we do not have human resources. If we do not have nurses who will vaccinate people, then we won't achieve the targets. Otherwise, availability. They need to invest in availing vaccines, because yes, nurses can go out of their way, educate people, but find that there may be no vaccines. So they need to ensure that there are no stock outs. Thank you.
So thank you so much, Paul, for that very short answer. David, I hope your questions are answered. And
yes, indeed. Thank you.
Thank you very much. So we can move on to Lincoln. Lincoln, are you still there? You can just ask your question now.
Yes, I am still here. This is Lincoln Nenan from Liberia. I am a registered nurse. I work in clinical research, and I am also a founder of a community health initiative called Teach for Healthy Lives. So as I listened to all these presentations about what could be the possible way forward in bridging vaccine inequity across the world, a lot of things came to mind, and one of which is how can community-based organizations help in supporting this kind of work? Nurses working in the communities with the people, how can they help? And I think there are a lot of ways that community-based organization can help in bridging this gap. And I've just outlined two of them that I thought to share with this panel today. And one is that community-based organizations require lesser resources we're talking about investing in nurses, and we're talking about issues of trust and mistrust. I think community-based organizations are closer to the people. If most of the communities that we want to gain the trust from are informal communities, and if we want to get to informal communities, we need informal approaches, and I think community-based organizations are very good at using the informal approaches to win the trust of the people. The second thing is that community-based organizations are closer to the people that we want to be convinced. So I understand that storytelling is very key. There is mistrust all around as we have listened to all our panels, and community-based organizations have possible solutions to help. And these are thoughts I wanted to share with this panel. Thank you very much.
Thank you very much, Lincoln, for that short and precise thoughts about roles of community organizations and in promoting vaccination. So while I have a question here on the dashboard. It's from an anonymous attendee, and the person is asking about the biggest barriers to integration of immunization, not just between COVID, OPV, or EPI, but more broadly with primary healthcare. So the anonymous attendee is asking about the barriers to integration of immunization, routine immunization. Rashid talked about vaccination and the challenges they have been facing in Malawi. Rashid, are you still there? Can you take up this question and put your thoughts forward?
Yeah, can you come again on the question? Yeah.
Okay, so there's an anonymous attendee asking about the biggest barriers to integration of immunization, not just between COVID and OPV, but more broadly with primary healthcare. So I just think this attendee is asking about the barriers to integration of immunization into primary healthcare.
Okay, thanks so much for the question. The first barrier is that of, I'll give an example of my district, is that of location. Some of the areas that these services are provided are, hard to reach. And during the disaster, we barely, visit these sites because we don't have, the only means of transport to reach there is the chopper. So we don't have a chopper, we only use vehicles. In such circumstances, we cannot reach there. As such, we cannot, integrate the services. For example, the other health community workers, they reside in such areas. But for us from the district level to take, for example, other services to integrate with them, it becomes a challenge. The other barrier is that of misinformation and misperception. People in the community, they choose other services that they can give. Even the routine immunization, there are some other people that they don't believe in routine immunization. Their children grow up without getting even any type of immunization. So when we integrate immunization, routine immunization, and other services, for example, SRH services, they choose to disguise all the services in general because there is only one service that they don't like. Yeah, that's what I can comment for now.
Thank you very much, Rashid, for that short answer. We've really spent way much more than our proposed time. I really appreciate everyone for staying over, our panelists, and then everyone who joined in through this webinar. I really hope that we've all gained and we've all learned a lot from our discussions, and then I'm hopeful that we would, go back and then think better about what we can do as individuals to improve and promote vaccination wherever we are. Thank you very much. I really appreciate the Nurse Now and the Stabbing Vaccine Institute for bringing up such an excellent platform for discussion and for promoting the immunization advocacy champions in their respective projects in promoting vaccination. Thank you for joining this webinar, and we'll be ending the webinar now. Do have a great day, everyone.
Bye.
Bye. Bye.